Right. So this is us entering into the duodenum. And if anybody would like to make a comment on what we're seeing here.
They are large swollen ampulla. But it's not just the ampulla that's swollen.
And a lot of punctums in the ampulla itself. It appears quite bulky. And you can see some debris.
Yeah, this was a difficult one because she's got chronic pancreatitis. When you see something like this whitish, then you're more, it's more. But with this swelling, it is possible that it will be faster. But generally, when you go into chronic pancreatitis patients, you will see some whitish stuff coming out.
So the plan was that an attempt was made to cannulate from the major papilla. And okay. So I think now would be a good time to show you the pancreatogram. You can see that some calcifications are already present inside the parenchyma when an attempt was made to start cannulating it. And our endoscopist had attempted, I'll just forward it, this was the wire passing through. So it has quite an aberrant course. It's not going in very smoothly. What I'm going to show you is when the initial dye was attempted to be passed, so right here.
Going somewhere through the pancreatic duct.
So the thought process right now for the endoscopist was exactly where am I? Is this extravasation of dye? And what is the course of the pancreatic duct? So for those that might have like slightly limited experience in pancreatic cases, I think this would be something that would alarm us. So attempts were still made to cannulate it, but they were unsuccessful. Now keep this pancreatogram in mind. And the procedure was ultimately abandoned and rescheduled for our senior endoscopist to do now. Do try to keep in mind 2 days later the procedure was repeated. Now we remember how the endoscopic findings were. Sorry, 1 second. Okay, so this is us going into the stomach. You can already see there's a lot of pus discharge. There you can see is the minor papilla. And a very innocent looking ampulla right now. So this is just 2 days after the procedure. You can still see some discharge from the ampulla.
Yeah, same patient. Dr. Shah is saying is the patient, same patient for sure.
How is the patient clinically?
Clinically, the patient said that her pain had gotten better.
Is there at the roof of the ampulla, is there another area of discharge?
Yes,
Like
and
that?
I will be showing that. I can't exactly
yes.
remember. Yeah, right here. We'll be seeing it shortly. So we went back just to see where the stream of pus was coming from.
Look like it's discharge.
Yes. Just as you enter the duodenum. You can see this area there.
Yeah. Right there is the drainage of probably the collection that
So
we
you
had
can see the
initially
minor
seen.
papilla there,
This is the
major
minor.
below that, and this is an area where.
Yeah. So I have more videos. Still, you can see this is the same area that we just showed, and there's still some drainage of fluid from there.
And there's drainage of fluid from the major papilla as well.
Yes. Now, if I take you, so the minor papilla, the major papilla, we couldn't cannulate it. It was the same story as the previous pancreatogram, that the wire wouldn't go too deep in. So the minor papilla was cannulated, and
See, I saw it when you saw this video. So I saw fluid coming out from this particular opening, and we could not cannulate from the major. Major wasn't taking us anywhere, and I looked at the minor, and so I said, let me have a look. So now you will see that.
so this was us. The wire went into the common bile duct. I'll try to do.
No, not
No.
through the major. This is our initial attempt trying to get into the system through the major papilla. But we couldn't. Whenever one of the things I've learned, and I was actually told by G.V. Rao, you've got a significant experience in ERCP and you can't get into pancreatic duct. Think pancreas PVC. Okay, so with experience you should be able to get into pancreatic. So a lot of times you're injecting dye and I get reports saying stricture, no dye going beyond, and it's actually not because of that. I go in and you see a minor papilla, you get it, and that's what the problem is. So
First, the pancreatogram was differentiated.
well, that dye was
That
going
is
into
the
a-
mystery.
into a separate space, which is communicating through that fistula that is actually draining in the duodenum. Obviously, there was a cystic. There's an abscess,
Sorry?
infective collection or
Yes,
whatever.
tubular.
So
And the wire went in very smoothly from the minor. And you can see the course that it's taken. I'm just going to take you forward to when we pass the dye.
you get these very advanced chronic pancreatitis patients who, and you can see one of the things that obviously we see a lot is, you see the calcification there, it's completely blocking the main duct.
Yeah.
So the head is, that part of the pancreatic duct is gone. And that's why I'm sure there has to be another passage. How old is the patient?
34. Now, if you remember the initial pancreatogram, you'll see that initially the dye was being passed from the bottom up, and now it's coming from the top to the bottom.
Again, if you see the communication, there's a very small communication. So I think what has happened is, this is what you would call secondary, or predominantly not the minor draining duct. But it's important because you managed to go and deep enough, and
Yeah, it's more like.
But did you S-fall this thing or not?
this was इसकी ASWL होगी ना?
GG, sir.
Yeah,
So it's the major should have.
Yeah, so what happens is, because your stones are completely
Yeah.
blocked, बड़ा मुश्किल है कहना कि how much of the stone is actually within the main duct and how much of it is within the branch,
Right.
and उसके साथ side branches में. But all our patients go to ESWL. So one of the things that you guys must know is that ESWL that we do for pancreatic stones is free. And we hardly get any referrals from Karachi. It's ironic that I get referrals from Lahore, but I have not had, practically, I can't remember anyone. There are so many big centers here. Hardly anybody comes to us for ESWL. We don't charge, we don't keep the patient. And
this
we
one,
have more volume than we can.
Can you say, yeah, this one, sometimes the when the major depth of pancreatic gets blocked for any reason, the stones or pancreatic mass, the minor duct is, dorsal duct is very small, but it opens up there.
Yeah.
So some of that is, sometimes it's called a pseudo-divism, or another would be acquired divism. So this is what, in this case, because the main duct is completely blocked, and the dorsal duct opened up, the problem may not have been very.
Thank you, Noel, that was good.
Just show you the last clip.
Last thing,
terminology wise, what's the difference between a calcification in a stone and secondly, parenchymal stone and ductal stone? आप सारी ये terms use करते रहते हैं लोग. So what's the difference between a calcification and a stone? कुछ तो कहें.
Stone is a complete phosphorus and that all the things sometimes they make up.
There is no difference. We use these terms interchangeably. So keep it in mind, a pancreatic stone is the same thing as a pancreatic calcification. Secondly, what's the difference between a parenchymal stone and a ductal stone? And Sadhbhai actually mentioned it a second ago.
Can you get parenchymal stones? That's the question. Can you get parenchymal stones?
It's a misnomer.
No.
So you need to really, you really need to understand the concept. A stone is a stone, and it's a calcification as well. Okay? It's the same thing. All stones occur in ducts. So it's either side branch or the main duct. Side branch वालों को कई दफा हम कह देते हैं pancreatic parenchymal stone, which is actually inaccurate. The stones are always in ducts, and they're always calcifications. They're the same thing. So when somebody says parenchymal stone, think side branches. They say ductal stone, they usually mean main duct. ये concepts बहुत ज़रूरी है clear होने for you to take on pancreatic endotherapy, because you get lost otherwise. So a stone is a stone, a calcification is a stone, and they're all in the ducts. Is it in your main river or is it in the side streets? That's the only thing.
One other question.
CT scan हमेशा वो आपको parenchymal calcification कई रोग लिखते हैं उसके ऊपर. What they really mean by that is it's in the side. Then they say ductal.
How's Bobby? और एक बात सुनी ये एक भाभी के पहले मैं पूछ रहा हूँ फिर एक सवाल
हाँ लेकिन अभी या लंच के बाद ये सवाल है क्योंकि सर ने बोला स्पेशल केसेस दिखा दो तो ये मैंने खोल दिया बस यही रहेगी Actually, sir, इसमें तीनों जगहों से फिर drain होने लगा था. This is the clip that I'm showing. It's draining from all.
Pressurized, it visualized, and then you also have your two openings.
Yeah, exactly.
Yes.
So it was the PD, fistula between the PD and the
Yes.
So we can potentially go through the fistulous tract.
Well,
Because it's big.
We didn't try to.
We didn't
Actually.
try to because I got into with the minor and I got into the minor thing, so I didn't try that. And we got good drainage of the thing, the patient stabilized and everything was good, so we didn't actually.
And we had
But yes,
simultaneous
we could
drainage.
actually candidate. If I could not have from the main or minor, then I would have actually inserted the canavan into the rest.
So why not?
So you don't know whether there was a small collection which is actually draining. So if you had a connection, you would not have been able to get into the pancreatic duct. So you don't know how pancreatic duct through the fistulous communication कैसे पहुंचेंगे. This is not directly from the pancreatic duct. It's from I believe that there was a collection which actually led to that.
Okay. And the second question was, why not surgery? I mean, this patient is more than likely going to end up with surgery.
No.
Why?
Why? I am a very strong believer.
34.
Decompress the duct. Decompress the duct and see how the patient does.
Well, the patient's done so well.
They are all from 2010 or before that.
Clear
But
the
I-
duct.
They look like
Pancreatic therapy has come a far way. I mean, like pancreatic sphincteroplasty. The pancreatic sphincteroplasty was something that was unheard of, right? But pancreatic sphincteroplasty now
Yeah,
I do it pretty much regularly.
decompress and see how they
पहले हम pancreatic का तो मैं आपको बता सकता हूँ कि जब when I was training तो pancreatic was a no-no.
Yeah.
2 सेंटर यूके में 3 सेंटर थे जहाँ भेजना पड़ता था. That's how it was. Pancreas divisum was like, oh my god. हम pancreas divisum, I think we do about at least 2 to 3 a month, if not more. So what you need to look at is we have ESWL, so we'll break those stones. We have the opportunity to go back in. We can dilate this whole thing. So, you know, you have options. Of course, surgery is an option. And whenever I'm seeing a patient, I always tell them that you have an option to go for surgery. You always give them that option. But majority of the people would say, what is surgery? I said, joining your pancreatic duct with your small bowel. Surgery pura katega. So they generally speaking would say, yaar agar sirf YouTube bhi dalni to this was not a bad thing, I'm fine. So this is what our experience is, but I don't know. They ask after be what is the acceptance of surgery in such
Very, very good.
Very good.
People prefer going in with the endotherapy. ठीक है उसमें we need to go with multiple sessions.
Yeah.
But then they're much happier with the endotherapy.
Achha.
And endotherapy, to be honest, works very well.
I think, you know, I haven't had somebody who would come to me saying, look, I'm fed up here. I want to have surgery. Not one patient in my.
आपने कितना अब काफी एक्सपीरियंस हो गया है you say with Dara and
Share. We are actually looking. Yeah.
Look at everything. Everybody answer is, oh, go to surgery, not realizing
No.
how.
So we have
so better in that.
And then हम दोनों center combine कर लें तो we'll have a very good
huge
number.
numbers. हमारा we've just got actually जैसे मैंने कहा था अभी आप लोग पहले बता रहे थे. We're just organizing the whole thing now. We have a research fellow. We'll have another research fellow shortly. So and we have 2 fellows. 4 लोगों का तो काम ही है. So one of the project is chronic pancreatitis. We have long-term data on them. We have follow-ups on them. So I think we should be able to take that out. Hopefully.
Sir.
Thank you so much. I'm not getting it. सुने रियाज सुने कल इन्होंने अपना स्टाइल दिखा दिया था महीने से पहले आज मैं आपको देख लिया Sorry guys, I'm not getting up yet.
All the best. Thank you.
Keep pushing.
I enjoyed this course.
There was another case.
Yes.
If the stones are not draining, even if the system is not draining in the presence of stones and B2BS and ESW, is it a possibility that these stones might, cause
These are two
stacking effect?
Look at the shape, look at the size. There's no way they're going to fall themselves. It's not like, I've not seen it like bile duct. But because they're सारे calcified stones, bile duct वाले तो थोड़े से soft हो जाते हैं, break हो जाते हैं, but I don't see that in such patients. This is 35, 30, after 25 के जो patients हम देखते हैं उसमें, this is not. In younger patients, you can have debris which actually breaks very quickly.
But the passive exit is still not there.
Doesn't matter. The pancreatic duct has started draining, so she's going to be fine. Now the question is, what do we do with the stones that are in the main duct? So obviously that patient would go to ESWL. Usually ESWL is also in someone like her is not going to be one second.
One more question: how about the option of endoscopy with EHL? Is that a possibility?
Okay. Yes, but it's very distal. If you have, Khalid is, I think, is one of the best anyway. So spyglass, my experience is that anything that's distal, spyglass is not good because holding the position is not good. Not easy. So in this case, I think the best option is to go for ESWL. If if the stones break, then you will have passage, and already you actually drained the system, so the patient should be fine.
What is the cutoff in both endotherapy and ESWL? Depending on the sizes, numbers?
When will I use ESWL? If the stone is big in the pancreatic duct and I can't remove it by endotherapy, which is going to be mostly the case. Most patients at this age will come with pancreatic stricture. I can guarantee that those stones also have a stricture somewhere. Because so even though the stones may flare up, the stricture may be there which you need to dilate. But younger patients, yes. I've seen younger patients in where the stone is there, 2, 3 chote small stones. You have to do a sphincterotomy. Sometimes you can do a. The chronic pancreatic duct is thick duct. It's not like a normal pancreatic duct. See, the concept that you're going to get pancreatitis with chronic pancreatitis is incorrect. You don't. Generally, you don't, because the duct is fibrotic, thick, already satyanas hua hota hai is duct ka jaise ye. The problem is when your duct is normal. That's when you have the issue with pancreas. So here you can actually dilate, you can do a lot of things. We can do spyglass, but most of the pancreatic, हमने जो spyglass किए not for stones to be honest, because एक तो हमारे justice center बना ये वाला ESWL है, लेकिन हमने ज़्यादा किए stent migration, stent fragments, those kind of things.
And how many sessions does it require like this base for the ESWL?
Oh God, where's the beat?
Actually, it's find कि बहुत variation होती है. It really depends on the type of stone as well. There could be some patients that have had more than 5, maybe 10 sessions, and there are some patients that respond to just a couple of sessions.
And there's some patients that are like magic. You do that and you can see that completely disappear. Okay, and in some patients you need to keep bringing it. So I think once we have the data, my assumption is the older the patient, the more difficult it is to do ESW. The younger the patient, the easier it is. This is my assumption, but I'm not. Are we ready for the next? फटाफट lunch नहीं तो ऐसा करें कि lunch serve करा दो, and if you want to present something while everybody is having lunch, तब भी हो सकता है, या you want to take a break, you take it.
I think we'll take a break for the EUS.
Okay.
And then I'll show you this.
So our failure rate again in pancreatic disease now is very, very low. But most of the patients, I'll tell you honestly, that have come to me from other centers, there are few obviously referred, mostly they come with the results. या cost की वजह से.
Yeah, which is इसको unpause कर दीजिए.
Significant percentage of majority are actually pancreatic.
Yeah, I'll go back and I actually don't think we'll be able to.
So my practice
I
now,
don't think.
when I'm doing ERCPs,
Well, no, there are lymph nodes. There may be, but they will be at the top of the stricture.
with an ERCP score,
You know? So these are iliac vessels.
wanting to look at the
So
minor
common, and that's the right and left. Can you see that? One is the
I do a little bit of suction and I want to see if there's any
So basically, we have lymph. I'm sure we'll have lymph nodes, but
There's
yeah.
no discharge, but it's prominent. That's gone into my system.
इससे आगे मैं जा नहीं पाता हूँ क्योंकि the structure is too tight and I don't want to push. Look at the Fuji image. It's just amazing. I really I started using this about a year ago, and it's just beautiful. Huh. So our second system is Fuji. It's got better image, it's got better repair service, and it's half the price.
Yep.
There's no rocket science, is there? We fell in love. When I used the Fuji first time, I literally just fell in love with this. And they give you, with the system, but certainly they give you tower, because their system is attached to endoscopy tower. And I needed a gastroscope, a slim gastroscope with more than 180 turn for my TIF procedures.
It's
and for
something
my
that
third
you may
space.
not be using
Oh,
for
my
a
third
long
space
time,
is
but
now TIF.
Farooq, we are with you.
So I'll quickly take you through this, Sadbhai. Can you hear me? Can anyone
we
hear
can
me?
hear you loud and clear.
So very quickly, this is a guy who have a rectosigmoid. I don't think it's rectosigmoid. I think this is actually a sigmoid tumor. They've asked us to see, there are lymph nodes surrounding the tumor that they were hoping that we can biopsy. The reason they wanted us to do this is because whether he's going to need a neoadjuvant or not. Had it been only a rectal tumor, radiotherapy has got more than 90% curative rates now. So in our MDT, all rectal tumors, unless there is another issues, they will really go for radiotherapy because the response rate is amazing. In fact, for pure rectal tumors, surgery is being done less and less because the rates are very good. Anyway, so when we get asked for rectal EUS, there really are three things that they're looking for. Number one, the relationship to the iliac vessels. Rectal EUS is like a colonoscopy. It doesn't start really from the anus. So you actually go to the rectosigmoid, you find the iliac vessels, and then you start coming back. It's like you reach the cecum and then you start coming back. In our center, that's really what the oncologist and the surgeon, they both want to know the relationship with the iliac vessels. So that's number one, which I'll show you in a minute. Usually at about 20 centimeters from the anal verge, you should be able to see iliac vessels. That's number one. Number two that you need to answer actually is the local staging, which is much better done with MR these days. EUS these days is rarely requested for local staging unless there is a lymph node which needs biopsy as well, then EUS is a better modality. And third is looking at the external and the internal sphincter and its relationship to the tumor. So therefore, our surgeons at King's, they do what they call ultra low rectal anastomosis. So it's important for them to know whether the external and the internal sphincters are spared, because then they can do sphincters sparing ultra low anastomosis. So but nonetheless, I think in this gentleman, I'll just take you, so we'll go, this is very starting point, and I'm sure you could be able, so this is the donut of the rectum, which is like your esophagus. It's very normal. I'm not going to spend more time on it because I just really want to go right at the far end. So this is as far as I'm going to go, and that's the tumor. I can't really go, I'm at this point about 19 centimeter from the anal verge, and if I'm just pull back, I'll show the trainees. So at this stage here, the tumor is T2. Why? Where's the ABC? Arrow चाहिए मुझे. मेरा ख्याल है छोड़ दो. ये रहा. I've got the arrow. So if I can convince you, this black line that you going all the way across, that's the muscularis propria, and the white outside is a serosa adventitia, whatever you want to call it. So at this point, I don't think the tumor is T3. I think the tumor is still T2. But let me take you just there you are. Can everyone see this? The muscularis propria is now been invaded, and I think there is adventitia involvement as well. In the audience, if this is very clear, and all the black structure that you see on the right of it is your iliac vessels. Unfortunately, I can't really go any further. The stricture, malignant stricture won't allow me. So we come back now. At this point, we haven't really seen any lymph nodes. So so this is the bladder on your right hand side. Can you see the screen?
Yes, we can.
And the iliac vessels are just at 6 and 7 o'clock. Yeah? Yeah, lovely. Sorry, I can't go any, but when you see iliac vessel, potentially that's pretty much the extent of your rectal EUS. You start coming back. Remember, the point was that we will do what we call is lymph node biopsy. At this point, we haven't really seen any lymph node. We keep coming back. In another 2 centimeter, we will expect bladder to disappear. And audience might think that we have found the lymph nodes at 3 and 4 o'clock. These are not the lymph nodes. Don't stick a needle in. This is your vas deferens. And the way to differentiate this is I come back centimeter out, they walk with me. Tubular structure, walk with me to the prostrate. And that's the prostrate on your 3 o'clock. Everyone happy with that?
Yeah.
These are not the lymph node. Please don't stick a needle in. So there are no lymph nodes, unfortunately. We're now far from the tumor. I just show you the external ending. So at this stage, as soon as we finish the prostate, you can, so just hold it there. Yep. So that sling type structure, the hyperechoic, that sling is your external sphincter. And if I come slightly back out, ab chhod do scope ko.
Yep.
And then you'll have a dark ring in a second, and that ring is your internal sphincter. There. Hold kare scope ko. This
I've shown it, but
black film, yeah?
I've shown that.
Yeah, so light. So it's done. There's nothing really.
Thank you.
There's just the three things you need to see in here. Sadly, there must be lymph nodes, but I think they'll be up on the sigmoid. EUS won't reach there. Chalo, thank you. Thank you. बस ये तीन चीज़ें हैं एक्चुअली यूएस में आपने की थी। अच्छा अब